Okay, it looks like we're live. I don't know if anybody is here yet. Let me get my screens lined up so I can see what's
Awesome.
Okay, so I have the live chat screen open so I can check on that whenever people join. If you guys want to ask questions, just go ahead and type them into the chat box, and I will make sure to get them to Tianna. So, okay, so I have the live chat screen open so I can check on that whenever people join. If you guys want to ask questions, go ahead and type them into the chat box, and I will make sure to get them to Tianna. So, okay, so I have the live.
Your microphone's off.
Okay, so I turned it off because I was getting feedback. There's a lag. I was seeing, I'm hearing the broadcast like 7 seconds after. Okay, so I muted that one. I think I got the right one muted. So go ahead, Tianna, if you would just tell us a little bit about yourself, your background, experience, and a little bit about the birth center where you're working now, because that sounds really exciting.
So first of all, thank you, Rachel, for inviting me to your first Ask a Birth Professional. I'm so excited. So let's see. Yeah, I am a labor and delivery nurse. Been a nurse for 4 years. I'm currently pursuing my master's degree at Frontier Nursing University, the first school of midwifery in the United States. I am very honored to be a part of that huge history and lineage. I am a lover of women. I love caring for women, and the babies are a bonus. And I'm currently at the Women's Birth and Wellness Center in Chapel Hill, North Carolina, and it is awesome. I mean, if you want, it is the dream. What Maureen Doctor be a place where women are supported. There is no better place to get to experience that, especially in the birth center. But they have a clinic as well. They have a beautiful boutique. They have a lovely tons of classes and free education. There's a mommy and me, baby wearing dance class too. They really got it going on. So I'm moved across country from El Paso, Texas, to take on that opportunity to get to see them in action. So I'm just soaking it all in.
Awesome. Amazing. So let's go ahead and jump into induction. How about you just start by telling us, and I imagine, okay, first of all, do you use it at the birth center? And if so, what are the methods you use there? And then what induction methods are more typically used in hospitals? Just a little compare and contrast. And what are the most common methods and how do they work?
Sure. So be induced all the way from, some people think having sexy time, all the way to a full-blown, medical induction. So we'll start with hospital. You could be induced using Pitocin, and you could be induced by breaking your water. You could be induced using Cytotec or Cervidil, cervical ripening. You could be induced using inside of your mechanically opens your cervix, and all the way to castor oil in an out-of-hospital setting, to using some herbs we like to call a little midwifery voodoo to get mamas going. So.
Okay, so what is the difference between Cervidil and Cytotec? I know there's some bad history with Cytotec. Some people are really scared of it. What's that like now? What does it do? And then when would you use that compared to Cervidil?
They are both used for cervical ripening. The major difference between, well, there's a lot of differences, but one of the major differences between Cervidil and Cytotec. Cervidil is FDA regulated for cervical ripening. Cytotec for cervical ripening, but it's a use of it. It's actually category X for and use in pregnancy. So with Cervidil, it kind of looks like a tampon that's been squished. It has a string on it, and it is placed vaginally behind your cervix. And if we see that you are having an excessive amount of contractions and that your baby's not tolerating, that might not be healthy for you, we could just pull the string. With Cytotec, even though it can be very effective, once a pill is in there, the pill is in there and it dissolves, and there's really not much you can do reverse those things, minus giving more medication to kind of stop your contractions, which is so.
Okay, so a cervical ripener could start contractions as well as softening the cervix.
Yeah, absolutely.
Okay, so I guess Pitocin is the other big one. What is it? How does it work? When did you most often see that given? What is the range of dosage?
So Pitocin is used like water in the hospital setting. Almost every mama ends up in some way, shape, or form if you have an in-hospital birth. So is the man-made version of oxytocin. Oxytocin is the love hormone. It is, the hormone that is released when you see your sweet baby, when you see your husband walk by and your favorite pair of jeans that he might be wearing, or you eat too much chocolate. So, except the man-made version is much stronger. The natural kind that you would release on your own. So Pitocin does not ripen your cervix, but it causes your uterus to contract. And out there that show that if you do need Pitocin to help your labor along or for induction, that if your cervix is ripe and ready for labor, that most women, I believe it was 98%, don't have to go above 6 milliunits of Pitocin. So rarely the case that we stay below 6 in a hospital setting. But if your cervix is ready and you are actually ready to have a baby, 6 is normally all you would really need.
Okay. So that pretty much covers hospital. You talked about things. Okay, let's talk about when and why people induce in the hospital setting. And I also, before I forget, I wanted to ask if that is kind of standard, because you've worked in a few different states, if that's pretty typical, that Pitocin is used like water, that you see a lot of inductions. So if it's been different in different places you've worked, also how often are women induced in the hospital setting? And then what are the reasons you have seen for a high rate of induction?
Sure. So Pitocin is widely used, across the board. I've worked at several different facilities. Probably the least amount of inductions that I have seen have been in a military hospital. Generally, military hospitals are teaching facilities. They have residents there and sometimes midwifery students there, but they are really tend to be more focused on practice. They are there regardless. They're not getting paid per birth or per cesarean section. So at military facilities, there's generally no rush for mamas to be induced. That's probably the lowest amount of Pitocin that I've ever seen be used. But yeah, that's pretty much across the board, that you go in and your labor isn't moving as fast as might deem necessary. Generally, Pitocin will. So some reasons that moms are induced. There is, of course, the elective induction, where maybe a mom lives very far away from a hospital facility. But generally it is, you are 39 weeks and you are exhausted and you are over it and your physician or midwife may offer I guess for you. Other reasons are just medical reasons, health reasons. So if you have gestational or preeclampsia, those would be very good reasons to be induced. Those medical reasons that would harm you or harm your baby, where your baby comes out of the womb. So it's much take better care of your baby and you, with your baby out than in. Few of the reasons why moms might be induced, but typically after 41 weeks is when you're going to have the most amount of success with an induction. And always, if you were going to be induced, you would want to ask medical reason to be induced, an induction, or kind of on the fence as to should I do this or should I not do this. Always, I mean, between 36 weeks and 40 weeks, your baby's brain doubles in size. Your baby knows when he or she is ready to come, and generally, they don't stay in for life. Yeah. So they're going to come out, one way or the other. But I've seen the most amount of success with inductions after 41 weeks.
Okay. I want to just get into a little bit just the reasons why those medical conditions would make it more dangerous for baby to be in. So you talked about hypertension and or preeclampsia, right? So if you could just explain that a little bit.
Yeah.
And also, what's gestational diabetes?
Sure.
Why would it be a risk?
So anytime there's a physiological or a health reason for you to be induced, you always have to take the benefits against. We'll just talk about blood pressure, for instance, the hypertension or the preeclampsia. That's very dangerous for mom and for baby to have your blood pressure be elevated at those dangerous levels. Our bodies are made to survive. We meant to kind of maintain that homeostasis or balance in our bodies. So as far as our bodies are concerned, if your blood pressure dropped, I'm going to say, oh, let me get all this blood and let me get all and it's going to be taking it away from baby. So relation issue that comes into play when your blood pressure is kind of out of whack. So when the blood flow and the nutrients and the oxygen isn't flowing to baby in the way that it should be, baby is much better off out than in.
Okay, and gestational diabetes?
Gestational diabetes, same thing. If having a big baby isn't a reason for induction, but having your blood sugars be out of balance can be harmful for your baby. So if your blood sugars are, well controlled and well maintained, then that would be something that you would want to speak to your practitioner about. Always asking, what are the risks and the benefits of anything that's going to be done to you? I've seen induced, for gestational diabetes, early at that like 37, 38 week mark. And then I've seen moms go to full term that have gestational diabetes. Just like every baby is different, every mom and every situation is different. So having that relationship with your midwife or your whoever is caring for you is very, very important. Level of trust and that level of understanding, and making sure you're asking questions until you really understand why to do something or why it might be beneficial for you and your baby.
Mhm. And that's a theme I expect we'll come back to a lot in this series, is asking questions. And definitely how you feel like you're being responded to is really important. If someone is impatient with you and they kind of don't want to take the time, then it doesn't sound like they're really valuing you or your experience, or just you as a human being. So that's a really good way to get a gauge on whether your provider actually respects you or not. So almost any of these topics, that's going to be a recommendation, I think. So Tianna, you had also talked about, you mentioned them being more successful after 41 weeks. So let's talk a little bit about, if you could, what successful looks like, and what, if it's not successful, what happens? How can that change labor? What would you be possibly looking at there?
Sure. So baby stays in, just the better. I mean, your baby is letting you know that I'm not done cooking. I'm not quite ready yet. And up to 42 weeks is the recommendation of how long you should let a baby cook. And after 42 weeks, that's when you're just at higher risk for your placenta kind of going, I've done my job, and your placenta is not working as efficiently in providing oxygen and nutrients. However, so every baby is different. Several things you want to look at are, how are my dates calculated? Where is my period spot on? And, I'm 100% positive that I know, when I got pregnant, because if you're 41 weeks, but you're actually 39, that's a big difference. Sorry, I'm getting off on a tangent.
No, that's relevant.
As far, but yeah, as far as 41 weeks, your cervix is becoming more ripe as time goes along, and generally after 41 weeks, studies are showing that inductions are much more successful. However, in reality, what difference does it make at 41 weeks? So what are the reasons you're being induced at 41 weeks is what you kind of need to ask yourself. If it's more days, wouldn't do much harm, except I have been pregnant 5 times, and I know that at 41 weeks you're exhausted and your pelvis is killing you. But if your baby is going to come on its own, generally it's going to come failed induction, and generally Bishop score, which is on a scale from 0 to 13, is above 8. That says your cervix is ripe and it is ready and receptive to being induced. I like to tell my mamas, your cervix is kind of like that bubble yum chewing gum, the old school, thick chewing gum. In the beginning, it's firm, wrapped to be to keep your baby in. But as your cervix becomes riper, it's like putting that gum in your mouth and chewing it, and you're releasing those sugars, and it's getting stretchy, and you're thinning out that bubble gum. And your cervix needs to kind of be in that place in order to be more receptive to being induced.
Okay, and if it's not successful, quote, is that cesarean? Like, what does that mean? How can that be? What's that look like?
So really, it just depends on how you were induced. I would always, again, every situation is different. Medical and different than, or medically necessary inductions are much different than elective inductions. The last thing that I would do is let practitioner break my water if I had not been making a significant amount of change, if it looks like things aren't going very well. If your water's not broken, you could just go home and wait it out and come back in 3 days, and you might come back in rip-roaring labor a few hours later. It really all depends on how you were induced. If it was Cytotec and Cervidil and or if it was a Pitocin induction and you're just not contracting. It all really is going to be dependent on what interventions were done. But generally speaking, as they say, one intervention leads to another intervention leads. So elective inductions are really tricky. You run that risk of, kind of opening Pandora's box, if you will, and at the hospital, you're not really going to get up and go home. So definitely having a plan in your mind, knowing what's going on with your baby is very important. And, like most things, patience is a virtue. It is what it is. And some babies don't want to come out until 42 weeks, and some babies come out 38 weeks, and every pregnancy is different. So.
And I think that's something that sometimes women don't understand. Once you are given, a ripening agent or started on Pitocin, you're in until that baby comes out. So if things don't move along as quickly, and then some hospitals, like you said, are willing to kind of wait and hang in there with you and let it take as long as it's going to take, and some aren't. So I think it's important for women to understand that once you do commit to that course, there's no turning back. If your body doesn't really mind and cooperate, you're staying in the hospital until you have a baby one way or another.
I think, and it's important. I think the most important thing to remember is you always have a choice. There's always an option, unless there is a medical reason where you are ill or your baby is ill. I would just stay away from inductions before, honestly, 42 weeks. If I hit 42 weeks and my baby hasn't come, then, there could be a logical reason why. Maybe my baby's not in the right position. Maybe my pelvis is smaller than we thought it was. Those instances, I can definitely see, a reason for induction. But weeks that I'm tired, you kind of want to stay away from that. I have seen a lot, especially in El Paso, that, they are 39 weeks and they're coming in for a checkup, and the physician wants to check their cervix. Your cervix is not a crystal ball. You could be dilated 3 centimeters, but entire picture. I'm dilated 3 centimeters, but I'm walking, talking, hanging out, not a contraction in sight. That does not mean you are in labor. So the new guidelines for is 4 centimeters for second-time mom, baby, and 6 centimeters if you are a first-time mom. So, if you go in and you're 38 weeks and your physician wants to check you, you have to think to yourself, what difference does it make? Is that information going to help me? How is that going to change my course of action, especially if your desire was to go into labor naturally?
What is the policy at your birth center on vaginal checks or practice? What's the common practice?
Say that one more time.
At the birth center where you work now, what is the common practice regarding cervical checks in the latter stages of pregnancy?
Sure. So really, I have seen moms. The amazing thing about out-of-hospital birth is, and the amazing thing about midwifery and that model of care is you are being educated and empowered from your very first visit. You know what's going on, you know what to expect, you're not in the dark, and you may have questions, but all your questions are welcomed and going to be answered. Come to the birth center are very educated and very empowered to how their birth experience is going to go. So speaking, there's not too many cervical exams, and moms come in, their cervix was never checked at all while they were there. But another thing is the birth center are not coming in to labor. So, sorry. So it makes a huge difference if you're going to have your, so why? What is the reason that my what is this going to tell me? How is this going to change the course of action? If I'm sitting here and I'm how many difference does it make if meters are, it really doesn't. So this is not a crystal ball.
Okay, so I think I'll just ask one question and then one more question. Well, if you had time to look at, I came across that article which was saying that the uterus kind of has two states. You know, there's the holding the baby state, and then there's like the having the baby state. And in the first state, when they're just holding the baby, and this article was actually in relation to breastfeeding, because breastfeeding releases oxytocin, and will this stimulate labor early? Because a lot of women are told that if they're pregnant, they shouldn't breastfeed because they might have early onset of labor because of the release of oxytocin will stimulate their uterus and contractions. And this article was saying that actually no, after a certain point, those oxytocin receptors on the uterus actually open up, and prior to that, they're not really available for use, and so that kind of chemical stimulation would be ineffective. But I was just wondering if you knew anything or had heard anything about that in relation to induction. It seems pretty relevant, and I've not heard anyone really discuss that or address it.
So yes, absolutely, 100%. To kind of take that into consideration all the time when we are and using Pitocin for induction. Your uterus has, it's kind of like a lock and key, for lack of better words. And then it's being, flooded into your system. But there's only so many sites that those, there's only so many locks for the keys. So you can have all of this Pitocin, flooding your uterus, and at some point it becomes ineffective. The receptive sites are full. They can't take anymore. So I got a chance to kind of glance at that study a little bit, but I know tons and tons of moms who have tandem fed and breastfed all throughout pregnancy. You release oxytocin all the time. Again, if you have sex during pregnancy, you're releasing oxytocin, and every woman is different. Every body is different. Every uterus is different. Every cervix is different. Every pregnancy is different. So just because one time this happened, doesn't mean the next time it happens, or maybe it does. So that's why it's just so important to be well supported.
One of the things that I in my lactation class is that the use of oxytocin or Pitocin in labor, because all those receptor sites are full, that can actually have an impact then on your breastfeeding, because everything has been flooded with this chemical. And so even in your mammary system, it can make it less responsive to your natural oxytocin afterwards, which your body needs to release your milk. So
100%. I see it all the time. You can definitely tell a difference when I worked in a hospital setting on those babies that came out and, mama was able to help them to get latched on, so quickly involved, whatsoever. So I think that's, that study is valid.
Okay, well, Tianna, we're going to wrap it up. Thank you so much. I imagine I can post this recording somewhere for all the world to see. We covered a lot. Probably could sit here and talk about it all day, though. There's a lot to talk about. So, I will go ahead and post that. And if people have questions, we can carry on the discussion on my Facebook page. So big thanks to Tianna for joining us. So good to see you, my friend. And I'm probably going to...
Thank you so much, Michelle. You're amazing. You're doing great things. So El Paso is very lucky to have you.
Well, it has been very lucky to have you too. You have left your mark, my friend. So I'm probably going to stop the broadcast and call you so we can chit chat.
That's great.
Okay, everybody. Thank you so much. Bye.